addressing health systems change and hypertension control. This fireside chat was moderated by Dr. Sally Ann Coleman-King, CDC medical epidemiologist. Anita Christie from the Massachusetts Department of Public Health shared her experience designing a detailed capacity assessment process and ongoing quality improvement work with sites. Diana Irani of the Massachusetts League of Community Health Centers provided an overview of the data reporting and visualization system used to deliver feedback to 1422 clinical sites in collaboration with the Massachusetts Department of Public Health.
Okay, good afternoon, everyone, and welcome to our Fireside Chat. So today, in conjunction with the National Centers for Chronic Disease Director, the National Association of Chronic Disease Directors, we'll be hosting the next in the series of our Fireside Chats. Today's Fireside Chat will center around health systems change, and we'll be hearing from our colleagues in the great state of Massachusetts and the work that they've been doing with their health center control networks. And so this is important today because partnerships are always key in the work that we do, and we love to hear about great partnerships and the work that is going on in the states, and so we're happy that they'll be able to share with us the work that they've been able to do and accomplish. So today we have Dr. Sally Ann Coleman-King from the Division for Heart Disease and Stroke Prevention, who will serve as today's moderator, and she's a medical epidemiologist within the division. So let me welcome Dr. King. We also have Diana Irani, who's the Health Center Control from the Health Center Control Network, and she's the director for the Massachusetts League of Community Health Centers. We will also have Ms. Anita Christie, who's the director of the Office of Clinical Preventive Services at the Massachusetts Department of Health. And each of our presenters today will share with us the work that they have that is currently going on and what they've been able to do with the funding that we have from our grantees, from our grants in our 1305 and our 1422 work. So again, let me welcome our presenters, and I'm going to go ahead and turn it over to Dr. Sally Ann Coleman-King.
Thank you, Letitia. So I want to welcome each of you as our guests today. We are really excited to talk a little bit more about systems change and harnessing the data that you have to drive your quality improvement activities. Just keep in mind, if you have any questions, please feel free to type them in the chat box, and we will take them one by one in between the speakers. But without further ado, I want to get started and introduce Anita. Welcome.
Thank you. Thank you for having us. So today the way I wanted to start off was to explain a little bit about how we implemented 1422 in Massachusetts. And part of the work, as Letitia said, was very much partnership-based. We really did take an approach where we looked at our landscape and realized in Massachusetts that we had a lot of things that were already going on in our state around hypertension and chronic disease. And the way our division is sort of set up, the Division of Prevention and Wellness at the department, we are all under the chronic disease director for the state. So we had a lot of alignment internally with the work that we are doing, as well as externally
with work that was happening outside of the division or with partners. We took time to really map out those strategies, and I think map out the landscape in Massachusetts, and I think you all have, as part of the presentation, did receive a map that really looked at everything that was going on. We knew that our QuinCo was actively working on hypertension. We had a prevention and wellness, we have the Prevention and Wellness Trust Fund that was also working on hypertension as a key component. We have a great partnership with the Mass League of Community Health Centers, and there was a lot of work that was happening within the community health centers that we wanted to map out as well. So we really took an effort and took some time to do that initially. On top of that, what we realized is that we didn't want to duplicate effort. We really wanted our efforts to be enhancing the work that was already going on. That we didn't want to put extra burden on people, and we really wanted to find communities that were in need. We picked 2 rural communities, and weirdly we went by counties. So we picked 2 very rural counties in our state, and also a county that had a lot of chronic disease in the areas. So we really focused there, both with the four of them. I think another key thing that was critical to how we implemented 1422 was really to look at the community health centers that we were working with and meet them where they were. We did an initial assessment that we were able to hire some consultants through our collaboration with the Mass League that were able to help us to really understand what was going on in each one of the sites, so that we had a good walkthrough initially of process and resources, technology, understanding of quality improvement strategies, what things people were already working on, and then in addition to that, building the community capacity to actually do some chronic disease work around hypertension. So we really were very sort of strategic and careful in our planning initially when we did this. Part of the work also was an e-referral process, and we really spent some time to, again, working with the league to understand sort of what that was going to take and be able to resource that in a way that was going to allow them to do that implementation piece. Right now it's primarily focused on resources in the community around diabetes prevention, but we have really encouraged folks to take a look at what other organizations in their community they can partner with to be able to implement some of the hypertension strategies. We took a pretty well-rounded view of also being able to look at the capacity within the communities and be able to understand what is there, what was needed, and provide some education around appropriate measurement of blood pressure, around quality improvement, and really because what we've really found out was that there's just a very basic understanding of quality improvement and what it is, but the actual putting the pedal to the metal and being able to implement those strategies within their organizations is really sometimes daunting. We were able to identify champions in each one of the organizations. That was really critical to the work as well. So I think it was very deliberate. It was very much a thought-out process with our partners. Mass League has been incredibly helpful and collaborative, and really has provided us with the data source that we needed to collect the data, as well as to provide feedback reporting for our sites. And the infrastructure in Massachusetts also includes partnerships that are with the Chronic Disease Partnership in Massachusetts. That partnership brings folks from all over the state, about 250 participants in that partnership that really are working on all dimensions of managing chronic disease. So they're working on built environment and healthy eating and safe streets, and a lot of the clinical work has been focused on hypertension and really trying to align the strategies within those very diverse partners within the clinical community of practice to be able to align the strategies that we're all working on together to have the greatest impact. So we really have tried to link everything together and tried to be very thoughtful in the way that we approached the work. Partnerships are key. Communication is key. I think both internally and externally, and the best ways to sort of do that are takes a lot of effort. So it really does. And I think also really understanding the dynamics and meeting folks where they are was another key to the way we approached the work.
Thank you for that. You know, I was listening to the talk about the needs assessment, and it sounds like you went really deep in trying to get an idea of what the true needs were. How long did that take? There were a lot of challenges to getting that to happen. We did have the consultants, and there was a series of steps that they went through.
So they would go through doing the assessment, making sure the champions were in the room, making sure you had all the information. So a real sort of quality improvement assessment up front. And then I would say probably each site took about 4 months at a time, but we really had people that were overlapping. We weren't just doing one at a time. They were often doing more than one at a time. So, and within all of that was also sort of a technical assessment of their EMR capabilities, their technical capabilities for doing some of the work, and then being able to support that work. But it included everything from the technical capacity all the way through workflows to resources to personnel, all the kinds of steps that people would really need to look at when they're analyzing a process and doing a workflow.
Absolutely. Sounds like an time-intensive but very important process. Yeah. So you mentioned that you had some champions that were helpful. And can you tell me a little bit about how you utilize that and utilize some of the other initiatives going on to enhance your work and maybe what policies kind of helped?
The leadership at DPH is very supportive of all the work across all of the elements of chronic disease management and chronic disease identification. And so much of what we do is interconnected because a lot of the risk factors are the same. So we can use hypertension as an example, but I think, similar things for diabetes and compounding that, obesity, a lot of even cancer for obesity. And so we work collectively on addressing some of the internally in DPH, addressing some of the risk factors. And we have done that in a way that's coordinated internally just by our structure at DPH. So we have internal leadership. We have the chronic disease director who is who's my boss, and is, in charge of all the chronic disease work within the division. So we are really coordinated in that way from a leadership perspective internally. Externally, in the centers, we were able to identify through the assessment sort of who would be the champion. Might have been the medical director, might have been the CEO, might have been a nurse champion, could have been a whole host of folks that were really taking up the charge and working towards improving the work within their space. But it was really, it differed amongst people. And I think another thing is that we were in a unique position where we have the opportunity to incorporate community health workers into the work that we're doing. We have an Office of Community Health Workers at the department that is really looking at standardizing training and really providing a framework for community health workers to work within many different environments. And the way we used community health workers in 1422 was to really have them become part of the clinical setting. They're involved in huddles. They're involved in and there's a champion at the department and through the office who is actually in charge of that work as well. And I think we're starting to be able to demonstrate the value of community health workers. And I think as we start to go into our ACO world, that will become more and more of a key personnel priority in order to control chronic disease.
Yeah, we've definitely been quite well aware of the importance of kind of having an all hands on board approach when we think about hypertension control and the asset that is. I think have we gotten a question from, where do I see it? Let's see. Sarah Dixon from, sorry, thank you. Sarah Dixon wants to know if Massachusetts can share their assessment.
Yes, we can. Attached to the webinar today, there should have been some things that had gone out, and the assessment was part of that.
Great. Evidently, NACDD will collect the resources and share them on the website. Perfect. And let's see, I did want to ask about, it seems like you targeted some priority populations, and I want to hear whether you were really, it sounds like you were very strategic in making sure that they were incorporated into this work. How did you do that, and did you use your data to try to help
We always use our data. We use what we have for our data. We do look at our hypertension prevalence in Massachusetts, but we were particularly focused on the undiagnosed hypertension, so we were targeting communities and counties that had either low resources, so often the rural communities don't have as many resources available to them. So we have a couple of rural communities where the health center may be the only thing around for, within that community, or where our lower socioeconomic folks actually get their care. So we did focus there. We also focused on a high burden chronic disease area in the state. So we really did take a look at our data, and also, again, not to overlap what was already being done throughout the state. We knew that the QuinCo was working on hypertension in million hearts, but mainly focused on small practices and not necessarily focused in the community health centers. And then we had other work through the Prevention Wellness Trust Fund that was focused on community health centers that may have been in different communities. So we didn't want to duplicate our efforts.
Absolutely, that makes sense. Well, I think unless we have other questions, nope, okay. Well, as you've mentioned, we are so fortunate to, well, thank you so much for that discussion. That does help us understand. And I know that you partnered with the Massachusetts League of Community Health Centers, and we're fortunate to have Diana here joining us to share a little bit more about the collaboration. Diana?
Hi. So we also very much enjoy our close working relationship with the Department of Public Health. We have similar goals, or if not the same goals, for our populations to be healthy. One of the reasons that it works so nicely is the way we're able to use data. So what we have at the Mass League, and several other states have this, it's a reporting product. I'm going to talk about the one we have, but there are other reporting products, so I'm not being vendor specific, except I happen to work with this one. But it's called DRIVES, the Data Reporting and Visualization System, which is a product of Zara Healthcare. And what that does is it takes the data from any EMR, it's EMR agnostic, and it uploads it every night. We have 31 FQHCs in our state on it, and just for reference, there are 38 FQHCs in our state, which is a lot for a small state. So every night we get this upload of every clinical encounter. So we're able to get the data right away, and it's normalized in DRIVE so that a blood pressure from Epic is the same as a blood pressure from eClinicalWorks or NextGen or Athena, or take your pick. So, and then that goes into our data warehouse. So we're able to work together with the health centers that did have different EMR systems in order to collect all of that data, and then partner with the Department of Public Health to work with the health centers to make sure the data is accurate, because data validation is a very big deal, and we have to make sure that the numbers are correct. And then what do you do once you have the data? What programmatic things do you do? So we work together with them with that.
It sounds really exciting. I would love to hear more about what you saw as a really valuable use of the data feedback that they received. If they made some sort of special quality improvement activity that you felt was especially impactful, what kinds of things did you see?
Well, with our 1422 collaboration, we actually added undiagnosed hypertensive patients, which had not previously been in our reporting system. So we added that in. So what that means is once you have that in there, you can use it to make registries. And with our software, you can prioritize the patients based on things like comorbidity, whether or not they have an appointment coming up in the next couple of weeks. So maybe you don't need to reach out to those people. Language, if you need a specific community health worker that speaks that language. You can zip code, like whatever way you want to sort and filter the information. One interesting challenge we had at first was that there was too much information. So you get a registry with 700-800 people on it. So that really taught us a valuable lesson about using the data to pare that down and then look at what's actionable. And the other piece of it is that we wanted to make sure that it was sustainable. So a lot of times we might have turnover at a health center, or really anywhere, where the person, there's always one person that does this, leaves, and then you're like, uh-oh, now what are we going to do? So the idea behind having a system is that even when that person leaves, all the data is still there, the system's still there, and someone else can come in and start working with the data.
And one of the things that we have done has been to create feedback reports, and there's another example in all of that. We have taken the data from the league and been able to create an actionable document for them to look at trends. So it's really a snapshot of the trend for a couple of quarters in a row to see if there's been any sort of improvements. And part of that is making it sustainable within drives and being able to have that available not just for the health centers that are within the 1422 program, but also statewide. So that will be readily available to them, as the registries will be for their undiagnosed populations.
And one of the other things that is nice about drives is because it is community health center based, once that improvement is in the system, it's available to all health centers that are on the product across the country. And there's over 200. So they would need to activate it, make sure the data is right, but they now have access to it because it's built, and we do training on it, both webinar and in person, to make sure that everything's working smoothly.
I think one of the biggest improvements that folks have made has been to really have a comfort level with dealing with the data. Mm-hmm. Folks have gained a lot of confidence. They've been able to work through the registries to be able to keep track of people who are undiagnosed and being able to track them over time. The community health workers have also been critical to that. I think they have also learned that the data, although initially we had trouble with quality, Diana, I think that it has definitely been improved upon. So people are more aware and more cognizant about where that little data element actually goes in the EMR so that it can then be extracted. So there's a lot of process that folks have worked through that I think has been a huge improvement.
Sure. Knowing that the data is being used makes it much more important.
Yes, people are watching, paying attention.
Absolutely.
Yeah, absolutely.
There's nothing scarier than getting a report and they're like, the data's wrong and this can't be correct, and then say, let's go record by record. We usually do a sample, and they're like, oh, I didn't document that, or that is in the notes box and it's not in the correct box. So we try to emphasize that, you have to have everything processed. You have to have a flow chart that explains exactly how to document something, especially you think blood pressure is not that difficult, but it's very difficult. We had to come to agreements about what if you have your blood pressure taken more than one time at the same visit. If it's high, then they wait a little bit, which one is reported, and the more you work with it, the better the data gets.
Absolutely. Absolutely. So what would you do? Do you have examples of what you might do if you didn't have an EHR in those circumstances? What would you?
We haven't had that. I think one of the things that we wanted to do was to make sure that folks did have that capacity. All of the community health centers in Massachusetts have an EMR. So we didn't really run into that. I think what we have seen has been the transition from one EMR to another EMR. That becomes a little bit problematic. There's a lot of folks that are transitioning from an earlier version of an EMR to, say, Epic, which is an integrated approach. Some are also integrated, some of the health centers are integrated in Massachusetts with their hospitals. So it kind of depends on where you are, but we are lucky in that I think it's 97% adoption of EMRs in Massachusetts.
Wow. We have a question from Tara in Colorado. How do you identify the undiagnosed patients?
Well, we have an algorithm that we worked with the Department of Public Health to come up. So I don't know, I'll send it out with my slides, the exact algorithm, but basically we looked for patients with an elevated blood pressure who did not have a diagnosis of hypertension. And then we put some dates around it, so it's not like if someone came in, 2 years ago or something. So it was, active patients.
Great.
And then from there, we're able to filter it down.
Thank you. Thanks, Tara, for your question. I think that we have one more question. Let's see. Yes, can your system upload patient self-assessment as a method to monitor patient progress?
No. There's a simple answer. No. We monitor patient progress by their ongoing blood pressures. But one thing we do have is when we use the e-referral system that Anita spoke about earlier, which is electronic referral to a community-based organization, we can map that in drives as well. So we could know whether or not they're receiving classes at the Y or some other intervention to see if that makes an impact on their health.
Great, thank you. We appreciate your questions. Please put your state and your name next to your question, and we will answer them soon. Let's see, I think I have another question, and that is, how is the information presented in the practices? You mentioned a little bit about the reports, but I'd like to know how often they got them, and whether, how you found a good time frame so that it wasn't too overwhelming.
We have been doing them quarterly to give folks feedback. I think that we also have regular contact with all 4 of the community health centers. So we have a team of folks that are working with the community health centers. So they also give us reports on a quarterly basis, and we are able to look at those reports and provide some feedback and technical assistance based on that. So it's an ongoing, iterative sort of process based on what they're telling us and what we see in the feedback reports. So we often look at over time, we can look at whether the undiagnosed hypertension is decreasing over time, and that's good because we know that people are getting services.
And on a everyday level, the centers use something called our patient visit planning report, where it lists out everyone that has appointments for that day, and it lists a bunch of flags. So one of the flags is undiagnosed hypertension, so that when that person comes in, they'll be able to address that with them.
So those that were identified as undiagnosed hypertensive, they were then contacted to schedule an appointment? How did that work?
There were some times where they were contacted, or they had scheduled appointments that were coming up, and then that flag would show up on the pre-visit planning sheet, and they would be identified for follow-up.
And if they came in for urgent care, we were also able to pull that up and identify the flag. So if they're coming in for a cold, you could say, oh, while you're here, let's talk about your hypertension.
That's great.
Trying not to miss opportunities.
Absolutely. That's what we talk about when we talk about our hiding in plain sight patients. Yeah. So this has been a fantastic discussion. We appreciate your work. It's really exciting to hear about how you're harnessing the data and using it to provide these reports that sound really useful to the practices, and so they were able to implement changes that help control their patient's hypertension. I know that everyone has more questions. Please feel free to put them in the box. You can also raise your hand, and you will be unmuted, and then you can ask your question out. We'll try to unmute you, and then you can ask your question aloud. Oh, good. Let's see. We've got what % of those with undiagnosed hypertension get a diagnosis of hypertension? So I guess how effective is it in finding them?
I don't think I know that. I don't think I know the answer to that question right off the bat. But I could try and find out and make sure that we incorporate it with, but I don't think I know that right now off the top of my head.
Great. It's a good question.
Mm-hmm.
So what have been some of the challenges that you faced in this work, and how have you addressed them, both of you?
I think data quality has been a challenge. We can agree on that. I think developing capacity within the communities can often be challenging, whether we're referring for example, DPP, or if there are self-monitoring programs in the community, or sometimes there's not that infrastructure that's already built. And so being able to build that capacity in the community can often be challenging, and finding partners. I think one of the other challenging pieces has been it takes time, and we want things to happen quickly, but understanding that this work is a progression of work, and that it takes some time to actually have some outcomes or some important process redesign that's going to happen. I would say another challenge is staff turnover in the community health centers. It's been an ongoing challenge for a couple of sites, and I think the other challenge, we've made great progress, but I think really incorporating the community health worker model into the practice. And they're not sort of just you refer them every now and then, but really having them be part of the team and having that be an important part of the work.
And I'd say from the health center perspective, there's a few challenges. First is focus. So we're starting accountable care organizations for Medicaid in our state, and that has been taking up the focus of pretty much everyone in the health center. So you have to always be thinking, how do I get ready for an accountable care organization for my Medicaid patients, but also for my non-Medicaid patients? We're going to have to still keep treating them. And then we also, unfortunately, have the opioid crisis hitting us pretty hard in our state. So a lot of funds have been channeled to help with that, which is very necessary, but it's not like there's a very large quality staff at every health center. Sometimes it's one or two people. So those people have to pivot and focus on the opioid crisis. However, I'll add a caveat that they're still learning the same skills that they need for all different health issues. So if they're learning how to use data, how to quantify things, how to make registries, and how to keep a sustainable structure with a provider champion and a committee that meets regularly, and some of them even have it in their incentive structure where you have to hit certain quality goals using the system, then that's helpful to everything.
Those are great examples, yeah. We do have a question from David Hudson. Are there ethnic minority populations that you are targeting?
It's regional. I think that we have a large Black and Latino community that we're targeting in the western part of the state. Also, we have a large Black and Portuguese Latino kind of population in the southeast part of the state, which is served. And in one of the sites, it's also a behavioral health site as well. So it's also incorporating those very, very hard to reach folks and managing them from a primary care standpoint as well.
Mm-hmm. And you can sort the data that way by gender, race, ethnicity, if there was something that you were targeting or had some kind of special effort.
That's great to keep in mind. We do have another question from Sangha Krupkar from North Carolina. What fields go into the e-referral in the community? And then does the community-based organization also need an EHR system or to receive the referral?
Oh, this is right up my alley. I'm so excited to answer this.
She's hoping for concrete examples.
So, absolutely. So we on purpose decided to keep the fields that go into the e-referral to be just demographic. And that was because of the privacy laws. Between the 42 CFR and then our own state has very onerous privacy laws specifically around HIV, but that doesn't mean just your HIV status. It can mean an allergy, a lab, a medicine, a test, anything at all. So I work with the health centers to set this up in their MOUs. I was loath to include any kind of clinical data at all, because if you don't, then you're not subject to the same rules. So it worked out well for the community-based organizations such as a Y because they already had their own intake process. And they certainly were not interested in housing clinical data because then they would have to have a BAA and then they would be subject to HIPAA, and nobody wants that. So we wanted to work with their comfort zone and meet them where they were and not change their intake processes. So a concrete example of this would be the health center sees that somebody, for example, could use help with their diabetes. And many of the Ys near us have a DPP program. So I guess it would be before they get diabetes. They're at risk. So then the provider, and that could either be the actual provider or a designee, such as a community health worker or nurse, would go into the EMR and request a referral, much like they would for cardiology or endocrinology, except the drop-down menu says public health referral. And then you choose the site, which is a YMCA site. And then once you do that and just kind of hit send, the YMCA has a web portal where they open up their mail, basically, and it says, oh, Mrs. Smith would be a good candidate for your YDPP class. Then they take it upon themselves to reach out to Mrs. Smith, and they type back into that portal, we've contacted Mrs. Smith, she's enrolled in the class, and that shows up in the EMR. So next time Mrs. Smith comes in, the doctor can say, oh, I see that you're enrolled in the YDPP class, how is it going?
That's great, that's a great example, thank you. We do have another question. What do you see as public health's role in moving forward and the importance of public health in developing these partnerships?
I think it's incredibly important. I think we know that we want to make we want to have sustainable partnerships. We want to be able to make sure that we're aligning our work to not only improve the health of the community, but really think about how we are measuring, how we are impacting the outcomes. I think one of the things that we've learned as part of the Chronic Disease Partnership is that there are many people out there that are doing work, and it's identifying the work that's being done and collaborating around it. And I think that that's one of the biggest and most important things that we've learned. And I do really think that that's the role of public health. I think that we can be facilitators and gatherers. And really helping people to come together to form creative partnerships that can be innovative and really have an impact. I think as we move into our ACO landscape in Massachusetts, it's going to be critical because people will have to develop their relationships in the community in order to impact the outcomes that will ultimately decrease the cost of care. So I think that those are some of the things, and I think that there are people that are really interested in doing this kind of work in the community, and we are often very energized by them. So it's been really great that way. But I really do see this as being part of public health's work moving forward, and that's really regardless of funding, and it's really understanding the landscape you're working in. That can really help to foster those strong partnerships.
Absolutely. I agree with public health being kind of the conveners of these separate groups to help the discussion at least begin. We have another question from Willie in Florida. Do you have a method to assure patient involvement in their own blood pressure and treatment decision-making process?
Well, I could say at the community health centers, it is the general culture and policy to meet patients where they are and then to employ motivational interviewing skills. Because if someone's not ready to care for themselves in that way, one thing we like to do is find out why. So one of the things that we're doing is looking at collecting more of the social determinants of health data through the Prepare tool, which is a NAC, National Association of Community Health Center developed tool, which is being sent out nationwide, and they have templates already built in EMRs. So we find out, maybe it's not the right time to address your hypertension if you have no access to food or transportation. Let's work on that first. Or childcare, it could be anything. So we try to find out what the reason is that they're not working already on their health and work with them.
And part of the work too that the community health workers do in the community health centers is help to identify those things up front and really intervene and assist people with community services and things like that. Some of the community health centers have social work departments or social services departments embedded within their structure, so it's also a good link. There's also lots of things that are either cultural or ethnic that also become barriers that unless you ask the questions, you won't know the answers.
That's true. We had that instance in one neighborhood where they would ask the older person, you know, would you like to come to the YDPP class? And they, yes, and here's the time and everything. But that person depended on their adult child for transportation, and no one thought to ask them about that. So when no one showed up for class the first day, we realized that we had to go back and figure out, you know, you may like to come, but can you get here? Those are two very separate questions.
Right.
That's a great point.
Yeah.
Do you find that keeping up with the community resources is a challenge? I know that you know that's a constantly changing
landscape.
Yeah.
We encourage our folks to sort of do that. One of the things in the 1422 and the combination with the 1305 work is to really, there's a lot going on around 1305 and building the infrastructure within communities. And one of the things that we really try and do between the components of 1422 and incorporating some of the activities that are happening in 1305 is to really make sure that people are aware of what each other are doing. You know, so there may be a lot of community work that's going into built environment, and knowing that, making sure that the clinical sites are aware of what's happening in the community so that they can relay that to the patients, and the patients can then take part in that. We have meetings annually, maybe twice a year, that really bring both components together to talk about the things that are happening. We also want people to have those ongoing communications, and we really try to encourage that within the communities.
Well, you guys are bringing up some really great questions. Tara from Colorado has a really important question, and that is about cost. So how expensive is this portal to develop, and can it be exported to other states?
Well, the portal itself was developed by the Department of Public Health, so I'll let Anita answer that.
I don't have an answer about dollar amount right off the top of my head. People were given a certain amount of money as an upfront payment to actually develop the e-referral process. So that was, and that took, I want to say about 4 months or so to sort of get that up and running. I can't tell you exactly how much the dollar amount was, but we know, but it was an upfront payment, and I can certainly provide more information about that if folks need it, but sorry.
And can it be exported to other states? Are there useful pieces that maybe?
It has a lot of interest from other states. I know that at the Department of Public Health, because I sit on their team too, so we're very well integrated. They've done a lot of presentations for other states and other public health departments that are interested in implementing this. I mean, it's web-based and community health center-based, so it shouldn't be too difficult to replicate. You know, that being said, you know, it depends on the software and the environment and all sorts of other things.
Sure. And as you said, folks that are already on using Drive, it's available to them already. 20 states?
20 states, over 200 health centers, and we already built the data elements into Drives for the e-referral, so they could see if there's a, you know, look at the subpopulation of people receiving services, and we can tell if they're actually receiving the services or just got the referral. So the ones receiving services, then you can correlate that to health outcomes.
That's great. So let's see. How did you overcome the resistance within the community health centers? That's another good question.
I wouldn't put that in the past. change is a difficult thing. It's never something that, you know, one project or one grant or 1 year can accomplish. It's an ongoing process. The main thing is the culture. If your culture at the community health center is to accept change and to work with it, knowing that things do change, your EMR changes, public health crises change, staff changes, and you're in a culture of change where you also are given time to meet and to even fail sometimes at things you're trying to do without being penalized, then you're much more likely to have successful change, as opposed to someone that just says they like change and doesn't provide meeting time for their staff, right, or gets very angry or upset if something doesn't work out.
And that's one of the things that we as the department and staff, internal staff, going out and providing technical assistance, constant communication, being able to provide resources, being able to provide ongoing education, whether it be around how to take a blood pressure or quality improvement, walking people through what the change might look like, and little steps at a time has really helped. I think, you know, when we look at data and we only look at data, things can somehow get lost in the translation. And what we really try to understand is what the barriers are within the organization so that we can impact them in a positive way. And I think that there's a sense of trust that's been built up over time, that folks are there and we're able to help and we're willing to help and we're just a phone call away. So I think that that has been some of the great work that staff have done to really work very closely with people within the community health centers to provide that support. That's been really helpful.
Our viewers are asking for a few more examples of the ways that the DRVS data are being used in clinical practice.
Well, the DRIVES data is used in many different ways. So one thing that it can do is benchmark, which is very interesting, and this is all in the context of clinical quality measures. So we have all of the measures built in there for UDS, which the health centers need to report on, HEDIS measures, lots of NQF measures, million hearts measures, so they can benchmark across the center by provider, by site, by team, by race, ethnicity, gender of the patients. We're adding in social determinants of health factors, so you could do that too. So that way you could identify any disparities. And another thing is the patient visit planning report that I referenced earlier. As the patients come in, clinically you can see what's missing or out of range. So you could say, oh, you know, last time you were here I see that this was out of range, without having to click through, you know, 20 pages of EMR data to see if a lab had been scanned in and somehow missed. So a lot of clinicians pick a few different quality improvement measures for the year, and then they meet monthly and they get a report on how are they doing. Are they doing colorectal cancer screenings up to the target range? Are they missing people? So it can be very impactful.
Sounds like a great way to improve efficiency and ensure that you're not spending too much time in one area. So we are almost at the end of the hour, and I wanted to ask a little bit more about your Prepare tool and where you expect to take this collaboration next.
Prepare first?
Sure. So Prepare, we are rolling that out in our state now. It does collect the social determinants of health data. About half of them are already collected from UDS questions already. So we're already halfway there. We're working hard to make sure that it gets used evenly and uniformly would be the correct word throughout different health centers, so we're not getting a lot of fluctuations in the data. All of the data elements are already in drives and they're already going through templates, so it's an easy push for the data to come out into reports. And then people are using the data for advocacy. We always say data is the currency of advocacy. And when you can say 40% of my patients have a transportation problem, then you can go to your local authorities and say, can we change the bus route? But if you just say, I hear people in my center have a transportation problem, it's not as impactful as having that hard data there. And there's a lot of ways I'm looking forward to collaborating with the Department of Public Health.
Yeah, and I think that we have had a long-standing collaboration. So I think that our collaboration with the League, it has been strong. It will continue to be strong. Again, Diana said we have a lot of the same goals. We have a lot of the same work that we are invested in. And I think one of the biggest things is that we're both really invested in the communities that we serve. So I foresee that we've tried to build some sustainability into the system, into the data system, so that folks can use it. But I think the ongoing work will continue even through the cycle, and then hopefully as we begin to work on priorities and things that might be coming down as listed priorities, whether it's from funders or from state initiatives, that collaboration will definitely continue.
That's great. I know that you mentioned having the data gives you a leg to stand on when you try to advocate for more services. Can you speak a little bit more to how this data is useful and how it may be used to drive some of your activities?
For hypertension? Mm-hmm. Yeah. I think, again, we use our state data as well as the DRIVES data to help sort of understand what's happening in the communities. Again, 30 community health centers, and really being able to, we work closely to share the data so that we can understand what's happening and what the priorities might be. Right now we know that a lot of the folks are very interested in and are moving into their Medicaid ACO work. And what do those measures look like? How can we align the work around those particular measures, as I said before? So I think the data drives a lot of what we do, drives a lot of how we prioritize our communities, our initiatives, and really our focuses over time.
Yeah. Please feel free, we have just a few more minutes, feel free to send more questions if you have them. Just as we're thinking about this initiative, how do you think about what do you think is the most effective process in institutionalizing this effort and this collaboration beyond 1422? And do you think that it has relevance to 1305 as well?
Yes, I think it does. I think being able to look at data and the institutionalizing that in a way that it becomes work of the entire organization, not just a couple of people, and redesigning workflows that assure that people are addressing the issues as they are identified. So I think that that's been a lot of what we have tried to do through the initiative. And I think one of the important things that we've learned has been that oftentimes clinical folks get very caught up in the clinical work and not really always understanding what's happening in the community, and being able to link those things together so that people understand that there are initiatives going on in their community, or there might be resources available that they can reach out to, and also beginning to develop some community-based partnerships that can really improve upon the care of patients, because we know that most of patients are only in an office visit for 10 minutes, and everything happens in the community. So what is the best way to make those? What are the best ways to make those connections? So I think that it definitely is linked to the activities that are happening in 1305 from the big picture perspective, but also when we think about 1422 and really what's happening on the ground and making those connections happen is really key.
Being that convener.
Yeah, being the convener. Yeah.
Do we have any additional questions from the group? All right. Well, it has been such an enormous pleasure to hear more about this work.
Having us.
We have enjoyed having you visit, and we thank you as our guests. We want to thank NACDD for your robust partnership and your facilitation of this fireside chat. Thank you so much.
Thank you.
Thank you.